Hi, John Jesse with Health Continuum here today in another of our series of Ask an Expert. And I'm very excited to welcome Dr. Brian Tudor, a cancer specialist, to have a conversation with us today. Welcome, Brian.
John, how are you?
Great. Let me just give a little bit of background to Brian. He's a graduate of the UCLA School of Medicine. He completed his residency in internal medicine and fellowships in hematology and medical oncology at the Universities of Utah. Board certified in internal medicine, hematology, and medical oncology, and professional experience of 37 years of clinical practice. Brian, let's just start. Tell us a little bit about your career and how does one become a cancer doctor? Did you choose it or did it choose you?
Well, it's interesting. My initial aspiration was to go into primary care, be an internal medicine doctor, an internist. And I became a little disenchanted with that, mostly because patients didn't do what you tell them to do. They didn't take their medications, they didn't stay on their diets, they didn't monitor their blood sugars, they didn't exercise, all the things that you point out in your book, The Health Continuum. And so I wrote, when you're a resident, you rotate through different clinics, and I rotated through the oncology clinic, and I was just captured by the patients. First of all, I knew what the patients had. And once you know what a diagnosis is, then you know what you can and can't do. Whereas, in general practice, sometimes patients come in, well, I'm tired, or I have a headache, or I don't feel well. And then you just go on this trek to try to find what's wrong with them. But when in the cancer clinic, you know what the patient has. They've had a biopsy, they have a diagnosis, and you know what to do. The other thing about these patients was that they were extremely motivated to follow a treatment plan, to be as healthy as possible, to be proactive in their care. So all these were very attractive to me. Plus, there was a lot of the science in oncology and hematology that I loved that had a lot to do with my background in chemistry. I was a chemistry major as an undergrad. So I think all those put together, they got me. So
They got you. Well, Brian, on behalf of all those you served over those 37 years, I'll just say we're very glad that it got you and that you dedicated your life to helping those. Had my major experience with cancer when I was just in my 20s, a couple of weeks before I was to be married. My dad passed away of colon cancer, and that actually was the experience that sent me on a lifelong quest to be healthy. And I've told people for many years, my dad died of colon cancer, and I can tell you for sure, I may die of cancer. A lot of it runs in my family, but I'm not going to die of colon cancer because, I'm not going to eat burnt hamburgers every night for dinner, which he did. I mean, burnt back, and I'm going to get a colonoscopy, which I have every 5 years. And so I know that those behaviors pretty much are going to guarantee I'm not going to be in the same position him. Tell us there are some other cancers that you can have some impact on. What would those be, and what kind of practices can people make part of their life to reduce maybe their chances and of contracting cancer? I know it's not a lot, but talk to us about those.
Well, there's quite a few things nowadays, and you bring up the question or the topic of screening for cancers, and having, like, say, colonoscopy, and I think they're actually lowering the age for your initial colonoscopy. I think it was 50. They're even down to 45. And in patients that are at risk, like people that have a family history, you're starting much earlier. So colonoscopies, mammography in women, and I'll point out mammography in women for their entire life. I've had some primary care physicians would stop doing mammographies on women when they reached age 80. And I can't tell you how many patients I saw with breast cancer past age 85, 90.
Really?
Actually, the incidence of breast cancer, if you look at if the risk of breast cancer is 1 in 7 women, that means 1 in 7 up to age 90. And so if like a 35-year-old doesn't have a 1 in 7 risk, it's the older you get. And really, if you look at all cancers, age is definitely a risk factor for developing cancer. And I think if you look at the theory behind that, I don't know if we want to get into that, but if you look at most cancers, probably the pathogenesis of cancer has to do with genetic aberrations. Now, genetic aberrations can be inherited, like perhaps you have an inherited gene that allows you, or that gives you predisposition to having colon cancer. But as we grow older, so our DNA is constantly being damaged and repaired. And as we get older, our repair mechanisms just aren't as good as they were when we were younger. And if you don't believe it, look at our gray hair and our wrinkles and our saggy skin and our joints that hurt, etc. But you can probably start relating all of these things, even heart disease, coronary heart disease, to genomic aberrations that occur on a natural basis. And so one of the things I think is really exciting in the field of oncology is that they're developing newer techniques where you can do simple blood tests that can detect strands of DNA from tumor cells. And you may pick these up very early on during the genesis of a cancer in a person. So if you could find those strands in the bloodstream, then you may be able to find the cancer much earlier. So it's
Is
kind of
that
a, go ahead.
is that kind of screening that I've read a little bit? Is that going to be, you think, available in like a yearly physical for most people soon? Do you think? Or
I don't think it'll be available. They'll probably, first of all, look at more higher risk populations just
that's
because of
it.
the
Okay.
expense of it. But I think as it becomes more use it on a more prevalent basis, the cost will come down because it would be great. So like, you go in now and for your routine physical examination, you have a cholesterol, fasting cholesterol lipid profile, you have a chemistry screen, a blood count, maybe a urinalysis, but wouldn't it be nice if you just had a blood test and it would say, oh, look at you have this problem. Like, you may pick up a inherited thing like a BRCA gene in a woman that would increase her risk for having breast or ovarian cancer. But you might find, oh, well, look at you must have an early form of lung cancer or pancreatic cancer or something. And then you could start looking closely.
Let me ask you about lung cancer real fast as an aside. I'm a non-smoker, no lung cancer in my, well, actually, I did have an uncle who did die of lung cancer. But setting him aside, I've never really thought any kind of screening, but I just heard recently from a, so-called expert who says, I think it is worth it to get screened. It's because it's a minimally invasive screen for lung cancer, even though I'm a non-smoker, and I'm going to do that the rest of my life. Do you have any thoughts on that?
Well, I don't know if insurance will pay for that. There actually is a what they call a low dose or low radiation dose CT scan to screen for lung cancer, but that's been mostly looked at in higher risk populations like smokers. And
Smokers and
like
that.
one thing you mentioned about, what can a person do to prevent cancer? And, one of my colleagues, once we were at a big conference, we were at a genomic conference that we presented here in St. George, looking at the genomic program at the St. George Regional Cancer Center. And his comment when they said, well, what can we do to prevent cancer? And he says, well, probably the two things you can do that's really going to make a difference would be, first of all, don't smoke or stop smoking. And second of all, wear sunscreen. I think other things, I mean, certainly being healthy, John, and I understand your quest to be healthy. I think that's great. I don't know, though, that certain diets or anything are going to make any difference in whether or not you develop cancer. It's interesting you mentioned about your father eating burnt hamburgers. Uh, and yeah, I guess the risk being all that charcoal, that he was in imbibing, not imbibing, eating. There was an interesting study done here in America in the 1980s that looked at comparing two populations, the LDS population that actually in Utah that actually has a high proportion of beef in their diet compared to Seventh-day Adventists that are vegetarians. And the reason they picked these two populations is because their religion does not, they don't smoke, they don't drink alcohol, so you kind of remove those risk factors. And they have a much, they have higher longevity than other population groups. And they found actually no difference in the types of cancers or the incidence or prevalence of cancer in either of those populations. So the meat equation, just doesn't seem to add up.
Well, it seems that what we're talking about then is if I want to reduce my chances of dying of cancer, I'm going to get the screenings so that I can be aware of anything that happens beforehand. Living a healthy life, eating right and getting movement can help me deal with it as I get it. But in reality, most of the cancers can come and we really don't have control whether they come or not. So talk to us about, because we're all going to deal with it on some level or not, right? I've dealt with my father, but I might deal with myself, my wife. It's part of this life, no matter what we do. There's no magic bullet that's going to stop it. Talk to us about how people can deal with it and prepare.
Well, it's we've talked before about. I think I mentioned, if you think of that, this is maybe scripturally based, but you think of cancer as no respecter of persons, and you're right. We're all touched by it. We've all had a family member or a friend or an associate that have been cursed with cancer, and how do we deal with that? And it's interesting. A lot of people would say to me, how can you go into oncology? You deal with all these depressing patients. They're all going to die, which is actually not true. But I think that first of all, we have to accept that that life is a continuum and that cancer may be part of that continuum. Death is part of the health continuum, right?
One end,
And
we're all heading there, baby.
exactly, we're all in for that. And then how do you once you're faced with a difficult challenge such as cancer or really any other chronic disease, and how your behavior is going to be molded by that. There's no question that'll be molded by that. But how do you use that in a positive fashion? And some people would say, well, how can you got cancer? How can it be positive about that at all? And when I used to have long discussions with patients about this and patients' families, first of all, I think that a lot of people want to give advice to cancer patients. They want to say, "Oh, well, you need to go down to Mexico and try this crazy treatment,"
Oh, I want to talk about that in a minute. So,
or
yeah.
you want to go to
Okay.
Johns Hopkins or MD Anderson, and so they go on some people get really lost just looking for the search for the cure. Where 2025 knows what they're doing at MD Anderson, and we can do whatever we want to right here in St. George. We do everything that they can do. Maybe there might be some research protocol that you could get on at a different medical center, a university medical center. But once again, when you start looking at treatment protocols or experimental protocols, you're looking at patients that probably don't have much chance anyway. They've already failed all their first line, second line, and third line therapies, and now they're grasping at straws. Um, so I try to urge people, to try to, like a lot of people get on the internet. I said that my competing physician was Dr. Google, because people would get on there and they'd come and start asking me all these questions that I just knew that they had been consulting with the internet. And it sometimes becomes quite confusing and it's difficult to somehow get these patients to focus and their families to focus on what is happening. So I think having a focus and having a plan and then going forth with that plan and feeling good about that. And I would always make sure that my patients felt good about the therapeutic plan that we were going to embark upon. And then just support. I think that a lot of people feel that giving support to cancer patients is, getting in touch with them and telling, well, I know this person that had this and they did this and now they're doing great, or they didn't do well. They died in 6 weeks, and people should be a little careful in how they deal with people that are stricken by this, because they can really affect their emotions. And certainly we all want to be proactive with somebody that we know, that we love. We want to help them as much as we can, but sometimes helping is just being present.
I just get diagnosed with cancer and I come to talk to you. What do you say to me? What do you say to people when that diagnosis comes to deal with this? How do I do that?
Okay. Well, first of all, um, I would review all of the data with you, what we have. Like what kind of cancer do you have? How extensive is the cancer? A lot of people get obsessed with the word called the stage of the cancer, but I like to look at it more as the extent. Like, is it localized? Is it widespread? Is it spread to a few spots? Does it look like this cancer is rapidly growing? Or is it a slow growing cancer? And that way the patient can start to get an understanding about, okay, well, what am I up against here? Like you might have something very simple that can be taken care of very easily and you're going to be cured from that. And you may have something that, no, this is going to be devastating for you. But then we would talk about what treatments would be intended, is there going to be surgery, is there going to be radiation, is there going to be chemotherapy, immunotherapies, genomic based therapies. So there's so many options that that we have to discuss. But I want you to feel comfortable about what you have. I want you to be fully informed. And then I also want you to be fully informed about what options we have for treatment plans. And I usually also want you to be there with your support system, whether that's
That's
your
important.
wife or your son or a good friend or neighbor or whatever, that's very important.
Your dog. I mean,
Yeah.
it's a no, right? Brian, you dealt with lots of patients over the years. And I would I would expect that some have dealt with cancer successfully, not meaning they overcame it or, such, but they dealt with that process successfully. And I'd imagine there's a percentage that didn't deal with it very successfully. These folks that dealt with this thing that is part of our life, is there a specific attribute or behavior that you could identify that say, yeah, people that dealt with it successfully did this, approached it this way?
The word that comes to my mind is people that were more centered, meaning they kind of knew what they were in for, but they were able to focus. And sometimes friends and family can be not very helpful in that because they want to just pull granddad or grandma every which way, and they say, "Oh, woe is you," kind of an attitude. But I think if the patient has a focus, and certainly if they have a positive focus, I mean, even if they know they have a terminal illness that they're going to die in a very short time, having that positive focus, and I think that people that are more spiritually in tune do better. People that have support of their family, people that just know it is, so have that idea of, yes, this is going to be the end of my life, but there's something beyond that.
I imagine
They
that makes a
would
pretty
do
big
much better.
difference. Yeah, and how they
Yes.
deal with it. What do you see on new treatments? What do you see currently and in the future? Treatment prevention? Anything big coming down or here that maybe people haven't heard about?
Well, I think that, the genomic screening is a big thing. You mentioned colonoscopies. I had a couple of normal colonoscopies when I was 50 and when I was 60. And now I just do a Cologuard where you send a stool sample in to a lab. And it's an interesting test. They look for blood in your stool, but they also do a genomic analysis. They're looking for DNA strands within your stool that may be being shed by colonic polyps or a cancer.
Ah,
So that's kind of cool when you think about it.
boy, and a
Uh,
lot better than taking that stuff. It's not the
oh yeah,
colonoscopy that.
yeah, it's the
Oh,
prep. Yeah, after that it's easy, right? So
oh my
it's,
goodness. Well,
yeah,
I didn't realize they were doing that
yeah,
DNA testing in the
yes,
stool sample. That's
that's true.
interesting.
And so there's an example of genomic testing. But I think as far as new treatments, I think the real advances that we've seen recently, first of all, are the multiple immunotherapies. Immunotherapies probably came into vogue in the late 1980s, early 1990s, but they've become quite refined now. And what they're based on, I mean, a real simplistic way of looking at it is to get the body's immune system to recognize the cancer. The cancer's smart. The cancer knows how to hide from our immune system.
Mm.
You talk about people that, oh, I'm going to take these vitamins and I'm going to eat these yams or whatever, and it's gonna heighten my immune system, even though there's no proof of that. But these medications actually are able to unmask the cancer to our
Mm.
body's immune system, and then our body's immune system can
Go get it.
facilitate facilitate the killing of cancer, and that may include other treatments like chemotherapy along with that. Then I think the other exciting part is genomic-based therapy, where we can take a person's cancer and extract the DNA from that cancer and then analyze that. And what we're doing is we're looking for mutations, and there may be mutations. So mutations can lead to cancer. They can lead to increased cell growth or uncontrolled cell growth or ability of the cancer to spread through the bloodstream or through the lymph stream. And so if we identify certain mutations, there may be drugs that can target that mutation. And there are many drugs that can target that mutation. And so the implementation of that combined with immunotherapies, and of course, what we talked about earlier, the implication that, well, if you could find somebody early on with a mutation in their bloodstream, then that we're going to probably find that cancer earlier and we're going to eliminate it before it becomes widespread.
That's great. So good things coming ahead. In summary, can I say this, that if you want to maximize your chances of not dying from cancer at an early age or possibly ever, get the screenings that are available. And can I say that if you eat in a healthy fashion and you get movement, it might have some impact on
Well,
prevention, but more importantly, it will help you deal with it if you do get it
right.
more
I'll bring that up. So if
effectively.
you look at patients that they'd come into my office and it was quite obvious that they hadn't been out of bed for months or hadn't been out of their living room chair for months, or they were obese, weren't active. they didn't do as well. In fact, there's a
Okay.
whole science. There's a grading scale we give patients. We call it the performance status.
Hmm.
And so, based on what your grade is, we can predict whether or not you're going to respond to treatment. And like if you have a certain grade of a performance status, if it's really low, then we don't even offer treatments because we
Wow.
know it's fruitless. So yes, being healthy, eating well, not being obese, exercising regularly,
It's
being
critical, it
mobile.
sounds like.
Very
Yeah.
critical. And then once you get cancer, I mean, I would see patients, maybe I'd be giving them a treatment, seeing them every 3 weeks, and they would come in and I'd say, "Well, it's quite obvious you haven't got out of bed. This was your occasion to get out of bed was to come and see me, and you haven't done anything the last 3 weeks, and then you wonder why you don't feel that well." So they got blame, "Oh, everything's because of the treatment," but, part of it is self-imposed. So,
All those lifestyles, those two critical lifestyle choices, which is what the health continuum is all about,
yes,
eating in a healthy fashion and getting the movement that keeps our
exercise.
bodies healthy. And so we'll be honest, we're going to not say that's going to prevent cancer. You still may get it, but it'll prepare you to deal with it
Yes.
at a much higher level, is what I hear you saying, right?
Well, I think, we talked about the emotional and the support groups, things like that. But I think, yes, being healthy, even though you say, well, how can I have cancer and be healthy? But you can be healthy, and that's going to help you try to overcome this or deal with it.
Appreciate that. Anything else before as we wrap up today? We do appreciate your time, Dr. Tudor. Anything else you
I
want to say
think
to
next
our
time
folks?
ever on the podcast again, I want to get a health continuum hat to wear like you, though, John.
We'll have to take care of that. All right. Well, we appreciate you being here. Another in our series of Ask an Expert. And as always, I will say to you folks, what are you able and willing to do today to improve your health? Let's do it. One strand, one change to improve your health and better propel you, in this case, to possibly deal with cancer someday. We're going to have a positive attitude and we'll be ready for it. Thanks very much, John Jesse with Health Continuum. Hey, don't forget to punch that button down there and spread it to your friends. Thank you.